So I go from the birth control pill onto the Lupron, stop the pill, continue the Lupron till the period comes. The moment the period starts, I will then, in women who have got normal ovarian reserve or high ovarian reserve, I'll lower the dosage of the pill, of the Lupron, and continue with the stimulation using low dose FSH predominant drugs. Some drugs like Menopur contain LH and HCG, and LH works like HCG. There's some of the drawbacks of LH. HCG has the same effect as LH, and if you add HCG, you increase the LH-like activity. So I prefer to keep the Menopur dosage that I give to a low level. I never give more than 75 units. And for the first 3 days of stimulation, I use a higher dose of the FSH dominant recombinant product like Follistim, Gonal-F, or Purigon. And then on the third day, I lower the dosage of the FSH and add a little bit of Menopur and continue that stimulation all the way until the follicles are adequately developed. And then I trigger with HCG. Here's the important point. When you trigger, you've got to use a high enough dosage because the HCG signals the egg to undergo meiosis. And if you give too little HCG, you will often get a higher percentage of eggs that are not fully developed. I think it's wrong to give less than 10,000 units of regular HCG, such as Profasi, Novarel, or Pregnile, or to use recombinant HCG less than 500 micrograms of Ovadrel. Ovadrel is recombinant HCG, and it should always be 2 little vials, not just one, in my opinion. And this is especially true in women who have a lot of follicles, namely the women that have normal or high ovarian reserve. So again, birth control pill, overlap with Lupron for 3 days, stop the birth control pill, continue the Lupron, wait for the period, lower the dose of Lupron, start on the recombinant FSH, which is the Follistim, Gonal-F, Purigon, with a high dose for 3 days. Then I lower the dose on the 3rd day and add Menopur, which is Menotropin, which contains both LH and FSH-like activity, and continue that combination all the way through to the trigger shot with HCG, where the dosage has to be 10,000 units, not 5,000, and if you use Ovadrel, 500 micrograms and not 250. That's the ideal for the woman with normal ovarian reserve. I also usually, if I'm going to do an embryo transfer in that same fresh cycle, in other words, I'm not going to do PGS testing of the embryo, which delays the transfer for a few months. I'll give the woman low-dose steroids in the form of dexamethasone, 0.75 milligrams daily, to try to improve immunomodulation in the uterus and improve implantation. How and to what extent that works, there's no certainty, but in my experience over time, it is an advantage. And in many of my patients, especially when I'm stimulating women that are older and those with diminished ovarian reserve, I use and add human growth hormone in the form of Sizin or Omnitrope, low dose, from the time of the Lupron start to the time of the trigger shot with HCG. There's some evidence, again, although it's controversial and not proven, but I believe there's enough evidence to me that it does have a benefit. There's enough evidence for me to use it in these patients because I think it works by enhancing mitochondrial activity in the egg and may improve egg development. It certainly has no downside if you use it for the short period of time, except in some very rare cases where medical circumstances preclude its addition. And when you do those things, 36 hours after the HCG trigger, the eggs are removed, they're fertilized by ICSI, which we do on everybody, intracytoplasmic sperm injection. Embryos are all taken to blastocyst. Those that make it may or may not be biopsied by PGS to see which ones are the most ideal. Now, in the older woman, we'll do that more readily because there's always an advantage to stockpile some of those PGS normal embryos over time to make hay while the sun shines, because time waits for no one, especially in women with diminished ovarian reserve and or older women. Okay, so that's the regular long pituitary downregulation protocol using an agonist lupron. Now, the second variation on the theme that I use very commonly comes to women that have got lower than normal ovarian reserve. The only difference here is that when the woman is taking the lupron and has her period, after 5 days of continuous lupron, I then switch from the agonist lupron to the antagonist ganirelix cetrotide or orgalutron, 250 micrograms daily. So at the point the period starts, there's a conversion from the agonist to the antagonist, and I call this, and please take note of this name, the agonist-antagonist conversion protocol. We overlap the two, and from that point onwards, the woman gets the antagonist all the way through to the HCG trigger rather than the agonist. And the reason is that the agonist will have the same effect of suppressing LH, but it also can reduce responsiveness to the stimulation, whereas that doesn't happen when you switch to the antagonist. Although there is one problem with using an agonist-antagonist conversion protocol, and that is that if you give the antagonist for that long, it often falsely suppresses estrogen in the test, not the production by the follicle, but the ability to measure it appropriately in the blood test you do. So we can't go that reliably on the relationship between blood estrogen and the follicle and its size. We got to go by the follicle size by ultrasound and the progressive rise in the blood estrogen level, not the absolute level it reaches. And that's important. One little addition, in both these protocols, both long pituitary downregulation protocols, which are really the mainstay of what I do, the woman, when her period starts after the lupron, has a blood test to see that her estradiol is low enough to start the stimulation, and an ultrasound to preclude or exclude the presence of ovarian cysts. Now, there's one last modification on the agonist-antagonist conversion protocol, which I reserve for women that have very, very low ovarian reserve, 0.1 nanograms per milliliters, maybe 0.2 and lower. In these women, I use a process that I introduced about 15 years ago, or even longer, called estrogen priming. Here, the only difference from the regular agonist-antagonist conversion protocol that I shared with you is that I give the woman estrogen by injection, estradiol valerate, also known as delestrogen, twice a week on a Tuesday and a Friday, as soon as the period begins after the lupron and the antagonist has started. She takes 1 week on the estrogen priming, which she gets on a Tuesday and Friday, and on a Monday and Thursday we test the blood levels of estrogen in response to the priming with estradiol valerate injections or delestrogen. And by doing this, it primes the ovaries, primes the follicles to respond better in cases of severely depleted ovarian reserve. And we've had babies occur in situations where such women have been unable to respond at all before. Now, these three protocols comprise 90% of the way in which I stimulate my patients. The dosages of the drugs will vary depending upon ovarian reserve and circumstances, but these are the three mainstays. There are other protocols that are used. One is called a flare protocol, where the woman again gets lupron, but she doesn't start the lupron until the period begins. She gets an agonist like lupron, buserelin, superfact when the period starts, but she does not do the birth control pill before. And she starts off with her first day of her bleed getting Lupron. What this does, as I told you earlier, the Lupron, like clomiphene, will expunge all of the FSH and LH out of the pituitary gland within hours. It's like squeezing a waterlogged sponge in your outstretched hand. It'll hit the ovaries with a high dose of FSH and LH. The FSH is good. The purpose of the flare protocol is like a springboard effect. By surging the release of FSH just before the stimulation begins, the woman will get a stronger effect from the drugs, the fertility drugs that follow. The problem is that she also releases large amounts of LH, and I've already told you that too much LH has a deleterious effect on egg and follicle growth. So that, in my opinion, what you gain on the swings by getting a woman to respond better using the flare protocol with more eggs is compromised by the quality of those eggs she produces because of overexposure of her follicles to ovarian testosterone brought about by the flare effect of the agonist. I never use flare stimulation protocols. I know many people still do and believe in them, and I respect their opinions. But in my opinion, it makes no physiological sense. It is especially harmful, in my opinion, when it's used in older women or women with diminished ovarian reserve. Now, a few little variations on the theme. When it comes to the trigger shot, you heard me mention HCG either as regular HCG, Profasi, Novarel, and Pregnal, or as recombinant HCG, Ovidrel, Ovitrel, or whatever it is. That's the way I like to trigger my patients, with a 10,000 units of HCG or 500 micrograms of Ovidrel. Some people use Lupron to trigger their patients. They give the women the antagonist starting, rather than when I start at the beginning of the cycle, they start 7 days into the stimulation. And then when they get to the point that the follicles are adequately grown, they trigger with Lupron. And the reason they use Lupron is because, as I told you, the agonist, Lupron, Superfact, Buserelin, expunges LH out of the pituitary. And remember, in nature, it's the LH surge that sends the eggs into meiosis or maturational division. So they give the trigger shot with a Lupron to avoid having to give HCG. They are making the woman's own pituitary surge LH. This is almost always used when the doctor is fearful that the woman's going to develop a condition called ovarian hyperstimulation syndrome, where they overstimulate, produce too many follicles, and it places them in jeopardy clinically. It can be life-endangering, and it will be the subject of a future presentation. We don't have time to do that today. But that's why they use the LH, because it reduces the risk of OHSS, ovarian hyperstimulation syndrome. But in my opinion, it does this at the expense of egg quality. So in the very women that hyperstimulate, such as women with PCOS that tend to have poorer quality eggs, you can also further compromise the quality of those eggs and therefore the embryos, in my opinion, if you use a Lupron a Lupron trigger. I never use the Lupron trigger. More recently, people have combined Lupron for the trigger with a lower dose of HCG. That works better, but it's still not as easily measurable. When you're relying on the woman producing her own LH to trigger the egg maturational process, and you have no way of knowing exactly what her pituitary response is in terms of LH, you're less likely to be accurate. So I don't like to use the Lupron trigger at all. There are other ways to prevent ovarian hyperstimulation syndrome, such as the process called prolonged coasting, which I introduced in 1990 and which I'll talk about in a subsequent or later presentation, but not today. Now, finally, there is another method of stimulation that is very, very, very commonly used in this country and beyond, where the antagonist ganirelix cetrotide or orgalutron is used, but not administered from the first day of the period as I described in the modified long pituitary downregulation protocol, the agonist-antagonist conversion protocol, where I start on day 1 of the period. Here the woman is stimulated with fertility drugs, and then around day 6 or 7 of the cycle, she's given the antagonist. She's given the antagonist ganirelix, cetrotide, or orgalutron, and the purpose of doing so at the later stage is to block an early release of LH, which can harm the follicles and harm the eggs, probably due to causing excessive testosterone production. The important point here is, in my opinion, this is not ideal in older women, and I believe so because in the 6 or 7 days that you wait before you give the first shot of the antagonist to block LH, LH can still be produced by the pituitary and compromise the egg development through excessive testosterone production. The last point I want to talk about is the use of the birth control pill in IVF. You often hear people tell you that use of the birth control pill is deleterious because it suppresses response. It does not suppress response if used correctly, in my opinion. Oftentimes, doctors give the woman the birth control pill, they stop it to wait for a period, and then they stimulate the woman, and then it takes the woman longer to stimulate and respond, and they blame it on the birth control pill. That may be the case, but the reason the birth control pill has this effect is because it suppresses FSH. And the production of FSH a week before the stimulation with fertility drugs begins is essential in order to get antral follicles to develop, which will respond to the FSH fertility drug. So if you overlap the birth control pill with Lupron or another agonist like superfactor buserelin, it will expunge the FSH out of the pituitary. This will cause development of the antral follicles, and then when you continue stimulation, you'll be fine. You can't, in my opinion, start giving the fertility drugs without having stimulated antral follicle maturation. That requires FSH, which the Lupron overlapped with a pill will do. But if you just use the pill, by the time the woman gets the period, there are no proper antral follicles matured. And now when you start the stimulation, giving the woman fertility drugs that contain FSH, the first 5 or 6 days are taken up producing and forming ripened or responsive antral follicles. And in my opinion, that is the reason why when you stimulate women under those circumstances, it takes much longer before you see a response. So if you use the birth control pill correctly, overlapped with the birth control pill, the Lupron, and don't start the stimulation coming directly off the birth control pill, there should not be any prolonged wait to get the woman to respond. The birth control pill is important, as I said earlier, in my opinion, because it gives the ovaries a breather by lowering LH-induced testosterone production. Now, I know that's a lot, and I ask you to think it through, maybe listen to it once or twice, and read the blog that I wrote on this topic. That's on my blog site. I'd like you to look at it, and if you have any questions, we can discuss it when you call up sometime to have a Skype consultation with me. I think I mentioned earlier on about how to reach me for a Skype, but in case I didn't, those of you interested in having a consultation with me, I urge you to call Patty Converse at 702-533-2691, and ask her to send you a questionnaire which you can fill in, send to me, along with as many medical records as you can get your hands on, and you and I can discuss your case in detail. You can also reach Patty by calling 800-780-7437 if you live in Canada or the United States. Patty, as I say, will respond by sending you a questionnaire, setting you up for a Skype consultation or a FaceTime consultation with me. You can also email Patty directly at concierge, CONCIERGE, at shareivf.com. And she will respond to you. Please, when you do email her asking her for a consultation with me, I urge you to give her your cell phone number so she can call you. That's really important. Finally, you can also sign up for a consultation with me by going to share@shareivf.com. Again, that's wrong. My apologies. It is www.shareivf.com. And when you get there, you'll find an enrollment form that you can sign up on, and that will reach Patty. Again, write in your phone number, and Patty will get back to you and set the ball rolling for a consultation, which I urge you to do if you're interested as soon as possible, because we're getting very busy. I hope that's helpful to you and not too confusing. If it is too confusing and I get feedback that it is, I will redo it and try to do it in a more orderly fashion. But I'm sure that if you listen to this and you do so in combination with a blog I wrote on the selection of the ideal protocol for ovarian stimulation on this very site, I think it'll be very clear. Thank you for your time. God bless.